All right, everyone. Good morning. Thanks for joining us here today for the last Grand Rounds here in November. I am very excited to introduce our speaker, Dr. Emily Jones, who will be talking about from missteps to mastery, understanding foot and ankle pain in primary care. Dr. Jones is an assistant professor here in our division, practices primary care and sports medicine at the Lowry Clinic. Dr. Jones graduated from Northwestern Medical School, stayed there for internal medicine residency before going to UCLA for both a sports medicine and a medical education fellowship there at UCLA. Then returned to Northwestern for almost a decade, where she was a primary care sports medicine physician working closely with the orthopedics department and was a team physician for the Chicago clubs, including during their 2016 World Series win. After starting a family, she moved back to Denver and, like I said, practices at the Lowry Clinic, both primary care and sports medicine. She's also passionate about physician wellness, earning a certificate as a life coach and supporting medical trainees and faculty. She is dedicated to medical education and helping the next generation of doctors thrive both professionally and personally. I'm very excited for her to talk to us today about foot and ankle pain. As I was saying to her before we got started, I'm hopeful by the end of the day that my differential diagnosis for foot pain has expanded beyond plantar fasciitis and stress fracture. And so questions as they come up along the way, please put them in the chat if you're attending virtually via Zoom. If you're here in person, raise your hand and I can walk over with a microphone. Dr. Jones.
Okay, well, thank you so much for having me. I'm looking forward to talking about foot and ankle pain in primary care. I think this is super common. I think in the last week and a half, I've gotten about 15 questions about patients coming in with various foot and ankle complaints. So I hope that you find this helpful. And I am going to warn you that we'll do some anatomy. So I'm going to kind of take you back to medical school. And so try not to fall asleep, but because I think anatomy is so important for the musculoskeletal exam. Once you know where something is located, then you can really narrow your differential. Okay, so let's see. There you go. Unfortunately, I have no disclosures. I'm happy to accept disclosures, but I don't have any right now. So our objectives today, we're going to talk about the common causes of foot and ankle pain that you might see in a primary care office. We're going to learn about what pharmacologic and non-pharmacologic interventions for foot and ankle conditions, and then when should we consult orthopedic surgery or podiatry. All right, like I said, we're going to go back to medical school and talk a little bit about anatomy. So here are the bones of the foot and ankle. And the ankle joint is considered the mortise, and that is formed by the medial and lateral malleolus and the tibial plafond. So you can see right here, it's this little tabletop. And the ankle joint is pretty simple. It plantar flexes and it dorsiflexes. And I have here the degrees for plantar flexion and dorsiflexion. It's about 50 degrees of plantar flexion is normal, 20 degrees of dorsiflexion. But really, it's most important to compare to the other side of the patient because everybody's range of motion is very different. Just below the mortise joint is the subtalar joint. So that is between the talus and the calcaneus right here. And that allows the ankle to invert and evert. And inversion is about 30 degrees, eversion about 15 degrees. Again, you're really comparing one side to another to see what's normal for that person. So on the lateral side of the ankle, we have a series of 3 ligaments. As you can see here, they're sort of wimpy looking ligaments, and that's why they're the most commonly injured in an ankle injury. They're named by their attachments. So here we have the anterior talofibular ligament. And this attaches the distal fibula to the talus. Down here, we have the calcaneofibular ligament, so calcaneus and fibula attached. And then in the back, it's the posterior talofibular ligament. And these are injured in a clockwise order. So the ATFL is the most commonly injured ligament, which we'll talk about a little bit later in the talk. And then they're injured in that order depending on the severity of the injury. So you're not going to get a PTFL injury without also injuring the ATFL and the CFL. And then on the medial side of the ankle, you can see there's this really nice, big, broad ligament called the deltoid ligament. And so that much less common, much less commonly injured. And you can sort of see why here. It's a lot bigger and stronger. It provides medial stability to the ankle. It helps support that medial arch. And it kind of prevents abduction, eversion. And as I mentioned, not injured very often. Also on the medial side of the ankle, we have some important tendons and other structures. I don't know if you guys remember Tom, Dick, and Harry from medical school. I relearned that when I got into fellowship. So that kind of stands for the order of these tendons, artery, nerve on the medial side of the ankle. So all of these structures course just around the posterior edge of the medial malleolus. And you've got the tibialis posterior, that's Tom. The flexor digitorum longus, that's Dick. And then is the tibial artery and the tibial nerve. And then finally, you have the flexor hallucis longus. So those are sort of the main structures on just behind the medial malleolus. And then you can also see that the tibialis anterior is coursing here just in front of the medial malleolus. And then you have a flexor retinaculum that kind of keeps all these structures in place. And then there's the syndesmosis. It's made up of a series of ligaments that sort of help provide stability for the mortise. It maintains that relationship between the distal tibia and the fibula. It's kind of right down here. And a syndesmotic injury is often referred to as a high ankle sprain, which I'm sure you guys have all heard of. And it's really important to differentiate between a regular ankle sprain or a high ankle sprain, because this is something that often requires surgery because it creates some instability of that ankle joint. Okay, so then moving on to kind of the anterior and lateral aspect of the foot and ankle, we have some more dynamic stabilizers of the foot and ankle. On the lateral side, here, we have the peroneal tendons. So those kind of course just behind the lateral malleolus. And then in the front, we have the tibialis anterior and then the extensor tendons here. And so the tibialis anterior, that's the tendon that you're going to feel when you're walking on your heels. And then the peroneal longus and the peroneal brevis attaches to the base of the fifth metatarsal. And both the longus and brevis evert and plantar flex the foot. Okay, so moving on to the physical exam. And I think the physical exam has probably been lost in a lot of primary care exams, but I think particularly for musculoskeletal complaints, it's really important in helping make the diagnosis. It's hard just to take a history and know what has happened, although that does help you quite a bit. And so, as you all know, the typical order of the exam is going to be inspection, palpation, strength, and then there's a series of special tests that usually have hard to remember names, and we'll try to go through some of those today. So the first thing I'm going to do, and not many people want to do this, but you have to take the sock off. And I try to put like a pad down on the ground, on the floor, just so that they don't feel like they have to touch the floor of the exam room, because who wants to be barefoot on that floor? But if someone's really coming in with a foot and ankle, try to take the sock off if you can. And then you want to observe the foot structure. And so it's fine to take a look while they're sitting, but it's also important to have them stand up, because once you put weight on the foot and ankle, you can see more about that foot structure. And watching them walk can also be helpful because there are some changes that can happen dynamically. And what I'm kind of looking when I'm just observing is there any evidence of pes planus, which as you know is a flat foot, or pes cavus, which is a high arch. And if you're looking at the back of the patient, a flat foot, you're going to see, I mean, basically the whole foot is touching the ground. This is what their footprint would look like. And you'll also notice that the Achilles kind of starts to point in. Whereas a high arch, the Achilles is going to point out, and this is what their footprint will look like. And so that can help as you make the diagnosis. It can help you make some recommendations on, altering or adjusting some of their biomechanics to help either prevent future injury or improve their current symptoms. So the other things you're going to be looking for, of course, swelling, bruising, any gross deformity. Not too many people come into the office with like bones sticking out, but you'll be looking for that. Okay. Oh, and just a quick thing about overpronation. So overpronation is basically when you have a diminished arch because the patient's foot is sort of rolling inward when they're weight bearing. So when they stand up, you'll kind of see their ankle start to come inward. And sometimes you can only see it when they're walking or running. So it's more of a dynamic overpronation. Okay, and then you're basically going to try to palpate all of the areas that we talked about in anatomy, and that's going to help you determine where the pain is. And so on the medial side of the ankle, you're going to palpate the medial malleolus, of course, the deltoid ligament, the posterior tibialis tendon, and then the navicular, which we didn't really talk about in the anatomy, but here it is right here. This is kind of an important bone to know about because it doesn't get very good blood supply. So it's a little bit like the scaphoid in the wrist. When it's injured, we're extra cautious and a little bit more conservative with the treatment. So you want to know if there's tenderness there. And then the anterior part of the ankle, the talar dome, the syndesmosis is sort of hard to palpate, but you might be able to determine if there's some tenderness sort of above the tibial plafond that might clue you into maybe a syndesmotic injury. And then the tibialis anterior is that anterior ankle tendon. And then on the lateral side, again, you're going to be palpating the lateral malleolus, which is, the distal fibula, and then those three ligaments. And some people kind of recommend that you actually palpate the PTFL first when you're doing the ligaments because it's usually the least tender, and then work your way towards the ATFL. Also, it's good to know that if it feels like the PTFL is tender, but the ATFL is not, then it's probably not an ankle sprain. So you're probably dealing more with a peroneal tendon problem. Because as I mentioned, you don't usually get CFL or PTFL injuries without first injuring the ATFL. And then range of motion. And like I said, this is going to be just comparing one person's foot to another. I think it's really hard to know. I mean, I'm not getting my goniometer out and measuring 20 degrees versus 50 degrees, but, have them point both feet, flex both feet. It can be helpful to do each plantar flexion and dorsiflexion with the leg straight and with it bent. So you can kind of isolate the gastroc and the soleus. So it can kind of help to differentiate where a tightness might be coming from. So for example, if you, I do this a lot with calf injuries. So if you dorsiflex the ankle and they have pain or tightness with the leg straight, but that gets better when you bend the knee, then that's most likely the gastroc. And that's because the gastroc crosses the knee, but the soleus doesn't. So you're kind of disengaging the gastroc when you bend their knee. Okay, then, you can do inversion, eversion, and again, compare one side to another. And then it's strength test, which is basically range of motion, but against resistance. So when you're doing resisted dorsiflexion, you're testing that anterior tibialis. When you're doing plantar flexion, it's the Achilles gastroc. Eversion is the peroneal muscles, and inversion is the anterior and posterior tibialis. And it's very easy for someone to plantar flex against your hand. So anytime I'm assessing the Achilles or the gastroc, I always have them stand up and I just have them like hold on to the door or a wall and then do a single heel raise. And that you'll really be able to more easily identify weakness or pain if you're, thinking about an Achilles or calf injury. So some special tests. There's an anterior drawer for the ankle, and this is to assess the ATFL if you've had an ankle sprain. I think this can be pretty hard to do actually, especially when you have an acute injury because it's usually pretty painful. But it's similar to the anterior drawer of the knee where you're trying to find an endpoint and assess for laxity. And so you hold you can see in this picture here, you're kind of holding the lower leg and then you cup the heel and you pull the heel forward. And you can try to see if you can watch the skin get sucked in. And again, I think this is a really hard, it's a really hard exam to do because usually there's like pain and guarding, but of course, the more you do it, the more experience you get. And then there's the talar tilt, which is basically assessing the deltoid ligament and the CFL, a little bit the ATFL. So when you're everting, and at that point, I'm really just assessing for pain. Like, does it hurt when I evert the ankle? That might indicate a deltoid injury, and vice versa if it hurts with inversion, CFL and or ATFL. And then there's some special tests for the syndesmosis. And these I probably am not doing quite as often. Syndesmotic injuries aren't all that common, especially in the primary care setting. But these are a few different ways that you can do it. This first one is called the external rotation stress test. So basically you have the ankle and dorsiflexion, and then you apply an externally rotating force. And so it's positive if that elicits pain. The squeeze test is where you actually squeeze the tibia and fibula together proximally. And what that does is if you have a syndesmotic injury, it kind of splays the distal tibia and fibula apart. So that's going to cause pain at the ankle if you push up at the more proximal knee. That's probably the one that I do most commonly because it's pretty easy. And then the cotton test, you're assessing for an endpoint and you're translating the talus within the mortise from medial to lateral. And that one's pretty challenging. And then the Achilles tendon. So anytime I'm assessing the Achilles tendon or the calf, I always have the patient lay prone. I think that's the easiest way to inspect it. So when you're looking at the Achilles tendon, you're going to be looking for any swelling, any thickening of the tendon. When you palpate it, sometimes you can feel little nodules that like right in the middle of the Achilles tendon, or any just thickening of the tendon, discontinuity of the tendon, of course. And then a Hadlin deformity is like a bony deformity in the back of the ankle, right where the Achilles tendon attaches. So you'll maybe see if one of those is there and then palpate for tenderness. And then the Thompson squeeze test is kind of what we have here. And I usually do both sides. So you basically squeeze the calf, and if the Achilles tendon is intact, then the ankle will plantar flex. If it's not, it doesn't move. So that's a good test for Achilles tendon rupture. Okay, Ottawa foot and ankle rule. So these are basically a way to decide whether you should get an x-ray or not. I get x-rays on most people, so I don't know that I always follow the Ottawa foot and ankle rules, but they do have a reported sensitivity of 100% in detecting fractures in adults, and it reduces the use of radiographs by about 30% for most people, but you have to follow the rules. And if you suspect a syndesmotic injury, then you should get an x-ray. So these rules wouldn't really apply. So basically the rules are for the ankle series, if there's any bony tenderness on the posterior edge or tip of the lateral malleolus, Or if they're unable, or the medial malleolus, so tenderness at the distal, medial, or lateral malleolus, or if they're unable to bear weight immediately, or if they're not able to do like 4 steps in the office. So if they're sort of limping around, that counts as being able to bear weight. And then you'll get a foot series if they're also unable to bear weight, or if they have tenderness at the base of the 5th metatarsal or the navicular. So the 4 bony points that you'll want to palpate to determine whether you need an x-ray are the navicular, the base of the 5th, the medial and lateral malleolus. And then of course, if they can't bear weight, you're going to get an x-ray. Okay, so let's go through some cases. Oh,
question
yeah.
first.
So for those, is it both, if you have tenderness at the navicular or the 5th, is it both the ankle and a foot, or is it just the foot?
Just the foot.
Okay.
Yep. Okay, so first case, 24-year-old male was playing basketball, jumped up to block a ball and landed on an inverted left ankle. He felt a pop, now has pain, swelling, bruising on the lateral aspect of the ankle, can't bear weight. And on physical exam, he has lateral ankle swelling, some bruising, tenderness of the ATFL and the distal fibula, and a positive anterior drawer, because you've gotten so good at that physical exam skill. This is a picture of Christian Braun, who is recently had this injury. So I think you all probably know what the diagnosis is. So I put this up more to demonstrate what my differential is going to be in this patient. So Achilles tendon rupture, of course, all of his symptoms are lateral. So that's probably going to be lower on my differential, but something to consider, especially if there was a pop and there's swelling. So you're certainly going to do the Thompson test. Distal fibula fracture is also a possibility. I mentioned that there was tenderness at the tip of the distal fibula. And then peroneal tendon subluxation is a possibility. That tends to be more of an overuse type injury and not necessarily something that would acutely happen with an inverted ankle. So in this case, this is a lateral ankle sprain. As I mentioned, those 3 ankle ligaments are not all that strong. So that's why people tend to sprain the lateral side of the ankle. And ankle sprains make up of about 14% of all sports-related injuries. And as I mentioned before, the most commonly injured ligament is the ATFL. And sometimes you can also see an avulsion of the distal fibula or the base of the 5th metatarsal. So I added a little x-ray here, and you can see there's a little, okay, you can see it. So there's a little chip off the distal fibula here. And I think this is an important point to make. You can also see this on the base of the 5th if it was a bad ankle sprain. And these are treated as any other ankle sprain. Maybe it's going to be more painful, but it's not treated any differently than I would any other ankle sprain. And then risk factors are, previous ankle sprain, any athletes that are involved in sports requiring quick cutting motions. And the treatment is the usual. So rest, ice, compression, elevation in the acute setting. You want them to start moving that ankle pretty early on. And so I'll usually have them spell the ABCs with their foot. So they're kind of doing A, B, C, but with their foot. And that just helps prevent that ankle from getting stiff. And then weight bearing is as tolerated. So if that patient walks in and they're not really limping, then I'm not gonna put them in a boot, probably. Maybe I'll give them a lace-up ankle brace or something to help provide a little bit of stability. But if they can't bear weight, maybe they do have an avulsion fracture, so they have more pain, then I'll put them in a boot. And what I tell them too is there's no set time that you have to be in the boot. It's totally based on symptoms. So I think a lot of people will go to ortho in particular, and they're so busy, they give you however many weeks you have to be in the boot and then, come back. But I really try to get people out of immobilization as early as possible. And so I let them do that based on their symptoms. So if you can walk without pain, then you can walk without the boot. Sometimes people have pain even in the boot, and then I give them crutches. So you can be as aggressive or conservative depending on the patient's pain. And then, yeah, lace-up ankle braces can be helpful. I know we have those in the Lowry Clinic. I don't know if they're at the other clinics, but those can be helpful too if they don't really need the boot, but they need some kind of stability. And then physical therapy is so important for ankle sprains. So the most common cause of chronic ankle pain is ankle sprains that have not been properly rehabbed. And so a lot of people will come in and they just have almost insidious onset of ankle pain. And it's because they had, 3 ankle sprains when they were a kid that they didn't really ever rehab. You just keep playing. And so now they've got this like chronic ankle instability. All the muscles have to work extra hard to keep the ankle stable because the ligaments are all stretched out. And so I recommend doing physical therapy for all ankle sprains. And I try to get the patients to do formal physical therapy if they're willing, but I also give them some home exercises if they're, because it's at least a home exercise program would be better than nothing to just strengthen up those muscles. Yes.
For those patients you just described that have chronic ankle pain because they've got those far in the past history of multiple ankle sprains, what's their course like? How do they improve? Does that pain get better, or is it pretty variable? Can you talk about that?
Yeah, so usually the pain does get better with physical therapy. There are some people that develop some osteochondral lesions, so that's kind of like damage in the cartilage within the ankle joint because of the instability. And those people are going to come back in a few months saying they still have pain, and that's when I would get an MRI to look for an osteochondral injury, which sometimes requires surgery, but sometimes not. But yeah, I would say most of the time those people do get better because they haven't even tried really strengthening all those dynamic stabilizers of the ankle. The other thing I want to mention here is, so I very rarely get an MRI for an ankle sprain, like no matter how bad the swelling and pain is. The x-ray, if the x-ray is normal, it doesn't really matter to me if the ligament is 100% torn, partially torn, not torn at all, if all 3 ligaments are torn. And I think what happens when people get MRIs is they see that all 3 ligaments are torn or one of them is torn and it looks terrible. And then they get sent to ortho because it looks so bad. But these are all managed conservatively. So even if you have a complete tear of the ligament, you're still going to try physical therapy first. A lot of those people get better with just PT. And it's really not all that common that surgeons need to do an ATFL reconstruction, for example. That's usually in people who have chronic pain that's not getting better with physical therapy. So we're still always doing PT first, regardless of the severity of that injury. Okay, so moving on to case 2, we have a 28-year-old male runner, posterior ankle pain developed while training for a marathon over the past few months. It's worse at the beginning of the run, then it kind of gets better and he's able to complete the run, but he feels increased pain the following day. He's tried resting. Every time he returns to running, the pain also comes back. He's tried NSAIDs. He hasn't reported any swelling and he never had any acute injury. On exam, there's no redness. There is some thickening of the Achilles tendon and some tenderness at the mid portion of the tendon. He has pain with passive dorsiflexion of the ankle and pain with single heel raise. So that's kind of what I was talking about, where you have them stand on one leg and see if you can reproduce the pain with that. And you might notice if you compare to the good side that there may be a little bit weaker on that side as well. Again, I think you all know what this is. The other things that I might consider here are, depending on where the point of tenderness is there a stress fracture in the calcaneus? And that might be like if they've got more tenderness at the insertion of the Achilles tendon, you might think about that. Plantar fasciitis is going to be a little bit further on the bottom of the foot, sometimes a little bit medially, but it's not usually the back of the foot or ankle. Peripheral neuropathy is going to be probably a different history and probably not tenderness on exam. But those are some things that I'm going to be thinking about when someone comes in with these complaints. Of course, Achilles tendinopathy is the diagnosis here. I put a picture of old shoes because this is a big risk factor for these injuries. Okay, so the most common site of the Achilles tendon to be injured is the mid portion. There's like a watershed here, so there's not very good blood supply to that middle part of the Achilles tendon. So that tends to be the most common area. The good news is that's also the the location that gets better. So pure insertional Achilles tendinosis is rare, but when it does happen, it's a lot harder to improve. And I was just going to make a comment about tendinitis versus tendinosis. So tendinitis is kind of the acute phase of the injury when there's still a lot of inflammation. Whereas tendinosis is when it becomes more of a chronic injury and you start to see micro tears of the tendon. There's like disorganization of the tendon fibers. And so that I'm treating a little bit differently in that maybe in the acute phase, the first 6 weeks, I'm prescribing a course of anti-inflammatories. But when it's more tendinosis, not going to really do a course of anti-inflammatories and going to focus more on the physical therapy. And then risk factors for this, training errors. So you're going to be listening for a recent increase in distance and test intensity or length of activity. Worn shoes, we recommend people replace their shoes every 250 to 500 miles, which for people who are training for marathons, like isn't that you can actually get through 500 miles pretty quickly. And it's for sure an investment. And then obesity can increase your risk, malalignment of the leg. So someone who's got like valgus knees, or if they've got pes planus, that can kind of increase their risk of Achilles tendinosis. Fluoroquinolones, we know, have a risk of damaging the Achilles tendon. And then hormone replacement, estrogen exposure from hormone replacement or oral contraceptives may actually cause changes in the microvascularity that can predispose a woman to Achilles tendinopathy. So as I mentioned, in the acute phase, we're doing NSAIDs, ice, making sure they're warming up properly. And this is another one of these things where some people come in with really pretty severe pain from the Achilles. So if that's the case, you can put them in a boot. And I usually give them a little heel pad to put in the boot, because having that Achilles tendon stretched out with the foot in dorsiflexion can cause more pain. So if you provide a little bit of lift, whether it's in a boot or in their shoe, that can just kind of help ease some of that pain from the stretching of the Achilles tendon. The physical therapy is going to focus on eccentric strengthening. So this is a story that I love telling because long ago there was an orthopedic surgeon who had really bad Achilles tendinosis, and he was trying to get his partners to operate on him to make it better. And they were like, no, we're not going to operate on you unless you tear your Achilles. So then he set out to tear his Achilles tendon. And so he did some eccentric strengthening that you can see here, where you're on the edge of a step, you go up with 2 feet and then down with 1 with the injured foot, and then up with 2, down with 1. And instead of tearing his Achilles, it got better. And so that is what we do to treat Achilles tendinosis, is eccentric strengthening. So as you all probably remember, that's when the tendon is lengthening while it's contracting, as opposed to shortening. So one of the other things that I use a fair amount for not just Achilles tendinosis, but tennis elbow and some other areas, or patellar tendonitis, is topical nitroglycerin. So they've done studies on this that show that it can actually improve tendon healing. And it is the same nitro that we're using for people with chest pain. We use a patch, and they keep it on 24 hours a day, switch it out every 24 hours. And it's a 12-week course, and you kind of put it near the area of the injury in just a slightly different place each day, so that you don't get a reaction from the adhesive. But that, in conjunction with physical therapy, has actually been shown to improve tendon healing. Platelet-rich plasma injections have been done. We have some sports medicine colleagues that do those if that seems like something that would be reasonable. And then we really try to avoid injections around a tendon, as most of you know, especially the Achilles. Okay. All right, next case, a 57-year-old male with history of obesity presenting with right heel pain for the past 3 to 4 months. He works as a bank teller, is on his feet most of the day. This one's for you, Steve. So the pain is located on the bottom of his heel. It's worse during the first few steps in the morning, kind of gets better as he continues to walk. and then worse again after he stands for a while and at the end of the day. He's tried ibuprofen, helps a little bit. He doesn't report any acute injury before this and no swelling or redness. So on exam, you take the socks off and you see that he's got pes planus bilaterally. There's no swelling or redness. He does have some tenderness at the anteromedial aspect of the heel, so kind of the bottom of the heel, but also the medial aspect, and pain with passive dorsiflexion of the toes, so sort of stretching out that plantar fascia. Okay, so here's the differential that I'm thinking of when this patient comes in. Again, calcaneal stress fracture, that's going to be, probably have tenderness in a similar area. They might describe similar symptoms, but with a stress fracture, you're probably not going to get that improvement as they walk. It's probably just going to get, maybe it'll even be better in the morning and then worse the more that they put weight on it. Retrocalcaneal bursitis, I mean, that's, there's a bursa in the back of the calcaneus. That's going to be hard to differentiate from Achilles tendonitis or plantar fasciitis, but plantar fasciitis is usually more on the bottom. And then tarsal tunnel syndrome. So this is compression of the posterior tibial nerve at the ankle. So it tends to cause pain on the medial ankle and the bottom of the foot. And that might be more tenderness on the medial ankle, and then the pain on the bottom of the foot will be more like not reproducible. Also not as common as plantar fasciitis. And of course, the diagnosis here is plantar fasciitis, which accounts for 80% of patients who have heel pain, and it makes up 10% of running injuries. And the peak age of incidence is between 40 and 60 years, but it can occur in adults of all ages. Risk factors are similar to most of these overuse injuries, so obesity, people who are on their feet all day. If they've got limited ankle dorsiflexion, so they're not stretching out that plantar fascia very often, they're just going to have a tight plantar fascia, and that's going to increase their risk of plantar fasciitis as well. Overpronation can increase their risk, poor supporting footwear. And about half of patients with plantar fasciitis will have heel spurs, which you see in this X-ray here. But also up to 20% of patients without plantar fasciitis also have heel spurs. So they can occur with plantar fasciitis, but they're not the cause of the plantar fasciitis. They're almost a result of the plantar fasciitis. Okay, treatment. NSAIDs, ice, stretching the heel cord early morning and throughout the day. Icing, I sometimes will tell them to freeze a water bottle or put a golf ball in the freezer and use that to kind of give them an ice massage. For people whose symptoms are pretty significant, I'll have them wear these posterior tension night splints, which are, you can get on Amazon. They have all kinds from like low profile to like basically what look like walking boots. And that just basically keeps the ankle in dorsiflexion and keeps that plantar fascia stretched out throughout the night. So you don't have that first several steps of stretching it out for the first time. Physical therapy is very important, walking cast, walking boot if necessary. So it's the same thing. If their pain is significant enough, I'll put them in a boot until it sort of calms down and then they can walk without much pain. Is there a question?
We have questions for case 2 that I was going to ask whenever you're done with case 3.
Okay, almost done. So you can consider a steroid injection. I personally do not do steroid injections into the plantar fascia for a couple of reasons. Probably the main one is that it can cause fat atrophy. And so that might actually cause more problems down the road. It also has the risk of rupturing the plantar fascia, which sounds bad, but actually solves the problem. So it's very painful when it happens, and then they can kind of get better. In fact, the surgical treatment is releasing the plantar fascia, but the main reason I don't is for the fat atrophy. This is a nagging, lingering problem. So it goes on for a long time, and I try to help patients. I try to manage their expectations by letting them know that. So we really try conservative treatment for 6 to 12 months. And as I mentioned, operative treatment would be release of the plantar fascia. All right, what's the question?
So I'll actually ask a question about case 3 first and then go back to case 2. So if treatment for plantar fasciitis is rupture release of it. So what's the natural function of it then? Like there must be some benefit to actually having it in the first place.
Yeah, I mean, it does. That's a good question. It does provide stability still, but I mean, it's like a lot of parts that we have that sort of theoretically have a reason. And you do want that stability on the bottom part of the foot, but it's not, I mean, it's like the biceps tendon, right? I mean, they'll release the proximal biceps tendon. So it's good to have, but it's not absolutely necessary.
Thanks. For case two, there's two questions. One is the topical nitro that you talked about. What's coverage like for that, for the Achilles tendinosis?
You know what? I have not gotten any reports from patients that it's expensive. The biggest problem is that I ask them to cut the patch into quarters for the first week and then go up to a half a patch. And then the treatment is a half a patch every 24 hours. And I use 0.5 microgram or 0.1 microgram. So the biggest problem I get is pharmacists don't want to cut the patch. And so I always write in the comments, like, okay to cut. The studies that were done on it, the patches were cut. But I haven't had any problems with insurance coverage.
And then also for Achilles tendinosis, one of the treatment options up there was plasma-rich
PRP.
PRP, excuse me, thank you. Platelet-rich plasma. What's the evidence behind that?
So I actually have not looked it up, to be honest, for Achilles tendinosis recently. I think there is some good data that it can help. It's a hard sell when it's $950 for an injection out of pocket. So I'm trying all of these other things before I'm even considering PRP. But I mean, I think for me, PRP to fix tendons feels a little bit more plausible than fixing someone's OA. Okay, so I'm kind of finished with cases, but there were a few other diagnoses that I just wanted to review because they're very common. So Morton's neuroma is something we often see in the office, and that's basically irritation of that interdigital nerve between the metatarsal heads and beneath the overlying transverse ligament. It tends to happen most commonly between the third and fourth toes. And when diagnosing it, here's Mulder's sign. You're basically compressing the forefoot between those metatarsal heads. And does that reproduce their pain? And it tends to be pain that's kind of described to be on the plantar surface of the foot. Sometimes people will describe numbness, tingling going into the toes. Sometimes it's pain going into the toes. It tends to be worse with exercise, better with rest. And the way we treat that, again, in the acute phase, maybe some NSAIDs. Make sure they're wearing shoes with the wide toe box. Metatarsal pads can help sort of offload that area. And then, avoiding repetitive toe dorsiflexion, so more firm-soled shoes. Steroid injection can be done if conservative treatment's not working. And I usually am getting imaging before I'm doing a steroid injection just to confirm that diagnosis, like an MRI, for example. Posterior tibial tendon dysfunction is another very common problem that we see in the primary care office. This is inflammation or tearing of the posterior tibial tendon, and it basically causes the loss of ability to stabilize a flat foot or to stabilize the foot, and it causes a flat foot. So here on the medial side of the ankle, this is the posterior tibial tendon, and it helps pull up that arch. It's one of the most common problems of the foot and ankle, and the tearing or the tendonitis can come from an acute injury, or it can come from repetitive overuse. And then you'll see the arch kind of slowly falls or collapses over time. And so people come in with pain on the medial aspect of the foot. It's worse with activity, particularly high impact activity, tends to be more common in women, people over 40, obesity, diabetes, hypertension. And then on exam, people have the too many toes sign, which is if you're standing behind them, this is what like a normal foot and ankle might look like. Here, they've got a flat foot, maybe some overpronation. And so you're seeing more toes on that lateral side than you should be. And then imaging, you can get imaging to detect osteoarthritis. You can get an MRI or an ultrasound to actually look at the tendon, but the treatment's going to be, at least to start, is going to be physical therapy. So rest, ice, NSAIDs when you're in the acute phase, immobilization if it's really painful. I usually have people get orthotics, and I usually start with over-the-counter like Superfeet. And then if those aren't helping, then I'll send them to podiatry to get some custom orthotics. And then after 6 months of conservative treatment, if they're not getting better, then I will have them see ortho. And then just to touch on bone stress injuries, this is going to be an insidious onset of localized pain that is worse with activity and weight bearing and better with rest. The exam, you'll have bony tenderness. I always do a hop test if I can. So that's when you have them stand on the affected foot and ask them to hop on it. If they say no, absolutely not, then I would consider that positive. But if they hop on it and it's painful, that's positive. And then I get an x-ray, which is most of the time, especially if it's just a stress reaction, is most of the time going to be normal. Here's an example of an abnormal one that I actually recently had. He had been running on it for quite some time. And if the x-ray is negative, you still suspect a stress fracture, then MRI is the gold standard. This third and second metatarsal shaft are the most common places to get stress fractures in the foot. But the navicular and the proximal fifth metatarsal are the ones to kind of know about, because those are higher risk. They don't heal as well. And so those need to be managed more conservatively. I usually make them non-weight bearing for a period of time. And then the risk factors are similar to all the other injuries that I mentioned. So training errors, poor footwear, of course, for stress fractures in particular, low bone density or female athlete triad is going to be potentially playing a role as well. And I just had to put this in here because we have a foot injury in one of our Broncos players. So J.K. Dobbins has a Liz Frank injury. The Liz Frank ligament is sort of, this isn't actually a great picture to look at the ligament, but it helps provide stability in the midfoot. And the way this injury typically happens is it can be high energy. So like a car accident, a fall from a height, a crush injury, and it can be a low energy where it's usually like a sudden twist of the foot. So in an athlete, it's often the foot is plantar flexed and another player lands on the heel, and it kind of splays you can see here, it like basically dislocates that second metatarsal. And then you get a disruption in the articulation between the medial cuneiform and the base of the second metatarsal. And that unfortunately usually needs surgery. So he is out for the rest of the season unless we make it to the Super Bowl. It sounds like he might be able to play in the Super Bowl if we make it. So the take-home points from today, as I mentioned, remember the anatomy of the foot and ankle, because that's going to help you identify what the differential is and what structures are in the area of pain. Physical therapy is the treatment for all of these things, and particularly for ankle sprains. I think sometimes we forget that. So to avoid chronic ankle pain and instability, prescribe physical therapy for ankle sprains. And then look for all the modifiable risk factors. So do they have pes planus, overpronation? Ask them about their footwear, and that can help with your treatment as well as preventing future injuries. Any other questions?
Thank you, Dr. Jones. I certainly have a broader differential now for foot and ankle pain. Question in the chat. Can you comment on orthotic insoles as treatment for plantar fasciitis?
Yes. So I would say, I mean, I usually try, first of all, I identify if there's any structural abnormalities of the foot and the ankle. And so of course, if they've got pes planus, overpronation, or pes cavus, then I'm going to probably be more likely to recommend orthotics. But even with a normal foot, if they're not getting better with sort of the usual conservative treatment, I usually try orthotics and see if that can help. Sometimes even just like a heel cup can be helpful for plantar fasciitis. It just provides a little bit of extra cushion. They have like little gel pads that are just the heel. Because custom orthotics are very expensive. Even over-the-counter orthotics can be kind of expensive as well. So just trying to keep things less expensive.
Can I ask 2 questions? All right. So question 1 is, then you went through all the risk factors, obesity, like overtraining. So I think often we're trying to actually treat many of those conditions or prevent them. So like, what is your universal precaution when we're doing our annual wellness visit and we're saying you need to get 150 minutes of exercise a day? Like, what is the low hanging fruit that you recommend for us to always counsel our patients on to help maybe prevent some of these things? Is it the shoe wear? Is it the cadence? Is it the type of exercise?
Yeah. So it's so different for everybody, because I'm thinking of, if you're counseling a healthy person who already exercises, then maybe it's the shoe wear. But if you're counseling someone who does not exercise and maybe has some arthritis, like, just walk, low impact exercise, just start by walking. So I don't know that I have like one thing that I tell everybody to prevent injury, because you got to get out there first, is like what I'm telling most of my patients.
Got it.
But I would say, yeah, I think shoe wear is an easy thing to counsel on, and something that the patient's sort of in control of. I think there's so many other risk factors, like, with regard to the anatomy of their foot, and that's a little bit, and maybe their gait, and that's a little bit harder to assess and fix.
Sure.
So it's a hard question. I wish I had the thing.
Yeah, it's like we want to get people involved in like exercise, but then you don't want to get an injury, because then it's probably this, downward spiral of I can't do it. Second question is, like, it feels to me that sometimes physical therapy is a black box, and you say physical therapy, but I don't imagine like all physical therapy is created equal. So for these ankle injuries, when we are saying you need to go to physical therapy, like, what is the counseling that we should be giving patients about the type of practitioner that they're going to, or the special certifications they have? Or 6 to 8 weeks later, when we come back and we're saying, well, how was physical therapy? And they say it didn't work. And it's like, well, what should we be doing? Like, how do we know, like, this intervention of physical therapy, like what it is, what's the quality, like, just give us your kind of like assessment.
Yeah. So I think one of the biggest problems, or one of the obstacles that I encounter, is that it takes 6 to 8 weeks to get into physical therapy at UC Health. So these are all fairly common injuries. And so I don't feel like you need a super specialized physical therapist to manage them. What I find is that when people come back and say it didn't work, how many times did you go? Because sometimes they said, well, I went once. Like, okay, we have to go more. Did they do, so I think, unfortunately, I don't know a lot of physical therapists in this area. I've been here 4 years. I probably should by now, but and so I don't have like specific people that I send them to. And I think getting in can be such a barrier. But I'll also tell people that, if the UC Health locations are not convenient, find another place that takes your insurance, and I'll send a prescription there, because no one's going to go if it's not convenient. So I almost feel like convenience and cost is more important than like who the physical therapist is, because nobody's going to go if it's a drive, or if it's really expensive. And if it's going to be expensive, because you still usually have a copay, even if it's covered by insurance, then that's where I really try to give them exercises to do on their own. And then when they come back, like, how often did you do the exercises? But it's a hard thing. And I think our system, unfortunately, is overloaded. And so they also don't, like, I've had patients come in and say, oh, after 3 visits, they said there was no more they could do. And I don't believe that.
I don't know who Ryan is, but Amber put in the chat that Ryan at AFW is
Yeah,
in all
I
caps
wish
for
I
foot
knew
and
his
ankle.
last name, but he's definitely the foot and ankle person at AF Williams. I don't know if there's more than one Ryan, but I'll try to find the last name.
Can you make a comment? I have a lot of patients who come in with metatarsalgia.
Mhm.
And I don't always like, I can't truly, like, I feel like it's a Morton's neuroma. What do you do with that?
So metatarsalgia is treated kind of similar to Morton's neuroma action. It tends to happen in people who like wear heels or tight toe boxes. And I do the squeeze test. So that's where you kind of squeeze all the metatarsals together. And if that causes pain, that can be suggestive of metatarsalgia. And then for them, it's going to be mostly footwear. So make sure you're wearing comfortable shoes. You can get a metatarsal pad that kind of offloads those metatarsals, spreads them out a little bit. That can take some of the pressure off. And then, yeah, making sure they're wearing wider toe boxes.
Last question for today. A high-level athlete has a severe ankle sprain, including a complete tear of one or more of those ligaments you were talking about. Do you still expect them to make a full recovery, including return to sport with PT alone?
Yes.
That's great news. Thank you, Dr. Jones. We really appreciate you coming and talking to us today, and again, really furthering our understanding of the foot and ankle. So thank you.
Well, thank you so much for having me.